The next section is cognition, how the brain works. And obviously there's a lot of overlap here with neurologists. We talk a lot about what the patient is thinking, how they're thinking, and there's a lot of clues into big issues like dementia too. So yeah, it's pretty much the biggest part of the MSE, and it's pretty variable too. And you can kind of see where we cater our mental status exam, and we really cater the cognition section to the kind of medicine that we're practicing and the kind of patient that we're talking to. But here are the general sections that we divided into: thought content and process, thoughts of suicide and homicide, patient insight and judgment, and then kind of the patient attention, memory, and intellect. And more so than the other parts of the MSE, there's a lot of inquiry in this section, right? You can't really tell what a person is thinking unless you ask them questions. So there's definitely a lot of observation here, but there's more inquiry here than in the other sections. The first thing is thought content. What is the patient thinking? What are their thoughts? And we'll talk a lot about these things when we go into psychotic disorders, because that's psychotic disorders are the problem with thinking, with cognition. So there's the things that you can hear about are delusions, paranoias, preoccupations, obsessions, phobias, poverties of content. Patients just don't have any thoughts going around. So again, we'll talk about this more later, but that's what thought content is, what the patient is thinking. Another section that we talk about in thought content is whether the patient is having auditory or visual hallucinations. Again, we'll talk more about this later. It's interesting to think though, because if you ask someone, are you having auditory hallucinations, it's really difficult for us as health providers to know if they're telling the truth or not. I mean, we can always have our suspicions and things like that, but there's no way to know for sure. And again, we'll talk about that more later. Thought process, though, is a little bit different. It's how a person thinks. So it's less related to the content, but the the process that the patient goes through when they're making connections in their thoughts. So the biggest question is, are you able to understand the conversation? Are you able to follow it? So the concepts we use here is the thought process logical? Is it goal oriented? Is it coherent? The other terms that tend to show some sort of psychopathy is circumstantial. Is it tangential? Are there flight of ideas, loose associations? Again, those are specific things we'll talk about in psychosis, but they all tend to show disordered thought, which is one of the main symptoms of schizophrenia. Thoughts of suicide and homicide. Obviously, this one I think is a little bit more self-explanatory, right? Are you having any thoughts of killing yourself? Are you having any thoughts of hurting yourself? Are you having any thoughts of killing or hurting someone else, right? Those are pretty easy ways to get those questions out. I think something that students usually ask is, doesn't it feel uncomfortable to ask those types of questions? And here's my answer for anything like this. Lots of things could be uncomfortable. If you ask them sexual history, drug abuse history, things like that. But if you remember, we're asking these things for information because we want to help patients. And so, we're not doing it because we want to gossip about them or things like that. So you just step forward and you're confident and you ask the question because you want to know, right? It's something definitely it gets easier the more you ask it, but this is exactly how I word these things. Are you having any thoughts of killing yourself? Are you having any thoughts of hurting yourself? The reason I differentiate to these two things out is, people from my generation and older, if you say, hey, are you having any thoughts of hurting yourself? They make the assumption that does mean killing yourself. And I'm not sure if that's true anymore. because of the way society has progressed, or just kind of the things that people these days know, what's more common. Self-harming is definitely something that's more mainstream than it was before, or at least the understanding of that phrase, are you having any thoughts of hurting yourself? Now you tend to see younger adults and kids, when you say, are you having any thoughts of hurting yourself, they tend to think more of self-harming activities. And so you want to ask about those types of things. Self-harming, again, doesn't necessarily mean that the person wants to kill themselves, right? It could be just a sign of anxiety. You ask someone if they want to harm themselves, and they say, yeah, I'm feeling like cutting. And then you ask them, why is that? What's some of your thought behind that? And they usually tell you that it's stress. Say, okay, so you're feeling overwhelmed, and that's why you want to cut. That's usually the answer, not I want to hurt myself, or I want to cut because I want to kill myself. And actually, you'll see a lot of friction between, again, this older generation that thinks of anybody that wants to cut themselves as automatically wanting to kill themselves. But self-harm is a different thing. So a little spiel there. If the patient states yes to any of these, make sure to document further. So even if someone says they would want to kill, harm themselves, harm or kill someone else, would they actually do them, right? This is the intent. Do you believe that they would? Okay, so even if they say no, they wouldn't, but you think that they would, that's something to take into account. And then ask if there are any plans. Do they have any plans to do this? And that just shows, or at least it makes more of a line for intent. Okay. Main thing here is, if you believe that there's a credible concern for harm to either themselves or others, then there must be some sort of intervention, right? If you're in an office, in an outpatient setting, then you've either got to get family involved or get them to the ER, or if it's something concerning, you may even have to call the police. Fortunately, I've never been in that situation where I've had to call the police, but I've definitely been in situations where I've recommended the patient go to the ER and that let them know that I had to contact family members. Insight and judgments. So insight is how well the patient understands their own mental health, right? You ask the patient what they know about the mental disorder they have. What do you know about schizophrenia? One of the ways that I kind of ask just in general is, how can I help you today, right? If a patient, I'm walking around a inpatient unit and geriatrics unit, I like to open up with that. How can I help you today? Because then it really gives an insight on, is that patient confused? Do they know why they're here? If they can tell that you're a health provider walking around, or that you're some sort of, like I said, technician or nurse or staff or whatever, that shows a lot of awareness. Whereas, they may not even know what kind of a building they're in. So sometimes I like to go with, how can I help you today? But to get a little more into it, if patients, at least know the name of their disorder and can describe it to you, it lets you know that, yeah, they kind of understand what's going on. So this is usually indicated as good, fair, or poor. If a patient really is confused, and I say poor on their insight, right? If they can't even tell you why they're there. I usually say fair if a patient knows the name of the mental disorder they have, but they don't understand how to go about it, how to help it. So someone that has depression and anxiety, they can say they have those things, but they're not really willing to, they think that medicine is the only thing that can help it, right? They're not willing to do any therapy or things like that. Then that would just be fair insight. Or for judgment is how well the patient deals with reality and the consequences of their behaviors. So, I mean, this is It seems like a silly question, but this is something that I've had to ask before. If you continue to set fires, what do you think will happen to you? Okay. If the patient, doesn't seem to understand or answers something like, well, gosh, I don't understand why the police would be upset with me, and they believe that, then that would be poor judgment, right? They have a very poor sense of the reality and the consequences. Again, I work with kids most of the time, so if you continue to not do your homework, what do you think will happen to you? Most of the time when you ask that sort of question to someone and they've got good judgment, but they're fighting you on it, they're still not going to answer because they want to be correct. So that's something you have to kind of pay attention to also. It's just a good way to see if patients understand consequences and realities of things, and if they're willing to accept them. So poor judgment would be a patient that isn't even able to understand that the consequences, whereas fair would be someone that you can tell that they can understand, but they're not willing to do anything about it. Attention, memory, and intellect. This is actually another kind of big section of the cognitive assessment of a patient. So these are a set of questions that assess different areas of cognitive function. A big part of this is the assessment of dementia. And for those of you that are familiar with something called the mini mental status exam, it's a very specific set of questions that are all related to testing cognitive function. So everything that's in this next section. So helps to assess dementia, concentration, which is a big thing in psychosis. Patients with psychosis and disordered thinking just tend to not have very good concentration and attention. General fund of knowledge and cognitive ability. So lots of different things here. We're definitely getting into the realm of neurology. For my uses, I don't use it as specifically as someone who's trying to diagnose dementia all the time. But there are psychiatrists that's their main goal, is they're focused on geriatric psychiatry. So attention. Attention is really the term we use for concentration and distractibility. So it's the ability of a patient to be able to follow what's going on. That's the attention, right? It's not they want attention. It's can they give you attention? Here's some really popular examples of tests, right? Digit span. Have the patient repeat a set of numbers forwards and backwards up to 8 digits. And see if they can repeat them to you. And this is immediately. You say the numbers, have them repeat it, and then have them repeat it backwards. The cutoffs that suggest dementia is if they can't do, if they do less than 7 numbers forwards, that's a problem. If they can do less than 5 numbers backwards, again, suggests dementia. So one of those things suggests dementia. 2 obviously suggests it even more. The classic spell the word world backwards. So DLROW, 5 points max if they get all 5 words, 1 point off if they miss a letter. So again, can they concentrate, right? It's easy enough to spell it forwards, but when you spell it backwards, you kind of have to flip it around in your head and think about it. So it makes the test more difficult. And then the real classic difficult one, serial 7s. Okay, so there are the numbers there, and I'm looking on this. Max 5 calculations. If they can get through all 5, they get 5 points. If they only get the first one right, if they can get to 93 and that's it, then they only get 1 point. This is actually notoriously difficult, but it's nice because that's what we want. We want tests with a high threshold to really test people. Like I said, they've really got to concentrate for this. So these are generally for dementia, but if you can tell a patient's just not cooperating with you, that's also something that's descriptive of the patient, right? If they're not willing to do these things, that doesn't necessarily mean they don't have dementia. a lot of times you talk to patients that have been asked these questions before, or they know they can't do these things and they get frustrated right away and they just don't want to do it. Again, does it mean they have Alzheimer's? No, but you definitely see a lot of patients that are struggling with Alzheimer's that don't want to do these things. Okay, memory. So there's 3 different types of memory that we ask questions about. There's the immediate or sensory memory, which is when a patient can listen to you say something and repeat it right away. So that digit span that we did before, that's part of immediate memory too. Now, the reason that it goes into more of an attention and concentration is because it's a long span of numbers, and you have to have them flip it around and do it backwards. So that's a lot of concentration. Whereas this is the question where you say, okay, can you remember 3 words for me? The words are jungle, lamp, and cherry. And okay, can you say those back to me real quick? When they say those back to you within seconds of you saying them, that's immediate memory. So within seconds. Recent or short-term or working memory, that's now you can turn that question around and say, okay, so jungle, lamp, cherry, I've told you those 3 words, you said them back to me. I'm going to ask you what they are in a few minutes here and see if you can't remember those. Okay, so now that patient has to sit there with those words while you're asking them other questions. That's short-term memory. You're seeing if they can actually keep it in their mind while other things are going on. So it's part of a process of retrieval. It's not retrieval from long-term memory, but can they take these objects and words and put them into their short-term memory and then recall them afterward. Okay, so it's a different type of memory. Other ways you can ask that: what type of medications did you take today, right? What did you do this morning? All these things would have to be within a few minutes or hours or things like that. Okay, and then remote or long-term memory. What's your social security number? Who are you married to, or who were you married to? What's your last name right now if it's a woman, to see if they can remember things like that. So that's definitely long-term memory. One thing you have to be aware of with all of these things is confabulation, right? Confabulation is when patients tend to make things up because they do have problems with memory. It's a defense mechanism. Think about it this way. If someone were to ask you, what did you do this morning, and you couldn't come up with it, that would be concerning to you. It would be concerning to you, and then it would make you nervous that something was going on, and then it would make you frustrated and angry, and so patients that tend to have a self-awareness that their memory is failing them, they tend to have confabulations where they just are really good at making things up. And again, it's just a defense mechanism. It's not they're not meaning ill will or anything like that. It's something that happens. So you've got to be careful about that. Basically, know what the answers are to the questions you're asking. It's something we've all been tricked of before. So there's lots of interesting things that you can see with memory, but the main thing is that the first 2 types of memory, your recent memory and your immediate memory, those are functional parts of memory. And those are the things that tend to be lost when you have mild cognitive impairment or dementia. Okay? So that's in contrast to patients that just have a normal aging process and they tend to forget things. Okay? So someone that keeps misplacing their keys, is that dementia or is that the normal aging process? It's kind of difficult to tell, but if they're having a problem with like a recent memory or immediate memory type recall and that's consistent, that's definitely mild cognitive impairment or dementia. Okay. Remote memory, though, people also often have difficulty with that, but the theory behind remote memory or long-term memory is not that you've actually lost those memories, it's that you have difficulty retrieving them. Okay, so you may not remember your social security number offhand, And, there's enough people in this room right now, or I say in this room like I'm lecturing to a room of people, there's enough people listening to this right now that some of you may not know your social security number right off the bat if you haven't used it in a while. Okay? Now, that's not a problem with your long-term memory. That's a problem with retrieval. If you got some hints as to what it was, if someone told you what the last four were, you may be able to fill in the rest. That's normal aging. Okay, that's normal aging, and that's just normal, all of us, all the time. So that type of memory loss isn't as concerning as, hey, I'm going to tell you 3 words. Can you tell me what those 3 words are in a few minutes? That's the main point of the memory thing, really, is we look at dementia and mild cognitive impairment. So here's a good rule of thumb, not always true, but it's kind of a way to think about this. If the patient complains of memory loss, that's more likely normal aging, okay? That means they're getting frustrated because they're like I said, they remember, they have difficulty remembering things, but at least they're trying. If the patient complains if the family complains of memory loss, then that's more likely mild cognitive impairment or dementia. Okay, so not an exact screening test, but you tend to see those patterns when you're dealing with just memory loss. Fund of knowledge, right, or just intellect in general. Here we're just trying to assess the patient's intellect, IQ. So fund of knowledge, can you name 3 large cities? Who were the last 5 presidents? What are the top, name 2 professional sports teams from this state. Those are just ways to just tell, how aware is the patient of their surroundings? How aware are they of what's going on in the world? Okay, so that's more intellect. And then vocabulary too is just an observed thing. You just can tell it from the words that patients use. Is it more high school level? Is it more college level? It's kind of a grossly intact type of situation. Abstract thought. So here we're trying to distinguish whether or not the patient has abstract or concrete thinking. And generally, when we think of development, we think of concrete thinking as being less intelligent, less mature thought processes, less developed in their thought processes. So that's what we're trying to see. Is the patient concrete thinking, or are they abstract, right? It's generally thought of as a stepwise thing where, you're concrete thinking at one point and then you progress into abstract thinking. You never generally go backwards unless there's a real serious problem. So here are some of the ways that we inquire about that. What are some similarities between an apple and an orange? If they say they're both fruits, that's abstraction, because that suggests that you're able to group things within a big category and understand things beyond their physical, restraints. Saying they're round, that's concrete. Okay. Another question I like to ask: what does it mean when someone says something is a piece of cake? The first question is definitely a higher threshold thing. The second one, way low threshold. If a patient can't answer this next one, that's really concrete thinking. But yeah, I think that makes sense. And this is another one of those pictures where if you click on the link, you find. But you guys know what kind of things I'm interested in. I look at these pictures, and this is an example of a really weird advertisement for like a cemetery, where like this one cemetery has become, really offended that another cemetery is talking about them. It just seems like a pretty benign picture, but apparently it's not. So I would check it out. So the example here, patient has spontaneous speech at appropriate rate, which is monotone with appropriate inflections and good articulation. I think the main question though is, did he really love Lily? And is that enough? I don't know. I don't know. So the example here, patient has spontaneous speech at appropriate rate, which is monotone with appropriate inflections and good articulation. I think the main question though is, did he really love Lily? And is that enough? I don't know. I don't know. So the example here, patient has spontaneous speech at appropriate rate, which is monotone with appropriate inflections and good articulation. I think the main question though is, did he really love Lily? And is that enough? I don't know. I don't know. So these are just the basics of a mental status exam. There's a lot more different ways that you can put these things together. Again, just as with any physical exam or history of present illness, you can cater to the type of chief complaint that you're looking at. So a couple of examples for dementia include a mini mental status exam as part of your mental status exam. If you look at these questions, you can see that a lot of these are already in the mental status exam as I presented them, and that's more by my design. I try and make as much of my mental status exam part of the MMSE so that, when I get certain answers, I can kind of see like, gosh, that really is going towards a cognitive problem, and so then I can just formally do a mini mental status exam on the patient. So here's an example of an MMSE and how to score it. If you're talking about, again, a lot of my patients, a lot of impulse control disorders like ADHD or ODD, then you cater towards more of their behaviors or what they're doing in the room. Are they fidgeting? Are they have a really short attention span? Are they running around the room and kicking things? Are they defiant with their patients? Are they defiant with you as a health provider? Again, just obvious changes in your questions. And then, of course, if you have a depression or anxiety chief complaint, you can also address some of these things more specifically too with these types of questions. I don't do a formal screening with the patient. By the time that I've talked to them, that I pretty much know what's going on. I just want to get more details so that we can basically. I use these as ways to monitor the patient's progress once I've started medication. So, asking really what the symptoms are of a patient's depression or anxiety. Is it fighting with their spouse, agitation? Is it isolating from family and friends? Things like that. This way you can just track to see the efficacy of what you're doing. When you're on clinical rotations, really just ask your preceptor if they have a specific way they like to do their MSE. And like I said before, everyone kind of does them differently depending on their patient population and depending on the health provider, what they've learned and what they prefer. So ask them. If not, then here's a basic outline. This is the one that I always use as the structure or like the base of all my mental status exam talks. You kind of right click on this document in here and then go to linked object and it'll open back up. I think it's like a 3 or 4 page document that just goes through. Obviously this front page here is the basic categories, and then it goes into more of like what are the appropriate terms for each and a very basic description of them. So yeah, that's pretty much all we're going to talk about today. Really the meat of psychiatry is talking about the actual diagnoses. So we've got a few lectures to cover, but this is the approach that we take when we're thinking about our patients. And so you'll see a lot of these terms repeated and a lot of these kind of considerations over and over again as we go through the different diagnoses. Thanks, everyone. As always, if you have any questions or concerns, just let me know, and hope everyone is doing okay. Talk to you later.